Thank you all. I titled this, Why Does My Hand Hurt? This is such a common thing that you all see in y'all's practices where they just point to somewhere on their hand or they describe their hand numb or tingling and it bothers them. So we'll talk about some of the most common things you're going to see, which is thumb-based arthritis, carpal tunnel syndrome, Dupuytren's disease, and trigger finger. Thumb-based arthritis is incredibly common. Loss of thumb function really debilitates the whole upper extremity. And so on history, the diagnosis of thumb-based arthritis can be obtained with just history alone. However, on physical exam, and the CMC grind test can be incredibly helpful where you simply just axial load the thumb base and create a circumduction type moment, and that can reproduce some crepitus or some pain at the base of their thumb. There are a variety of non-upper measures for thumb-based arthritis, and this is oftentimes the mainstay of treatment. As we know, thumb arthritis is incredibly common, but very few people ever go on to have surgical management. And so these patients may present to your urgent care clinic or your walk-in clinic with just a flare-up of their arthritis. So there's a lot of things we can do to calm these things down. And those include activity modification. Those are buying a jar opener or a pill bottle, easy open pill bottles. You can use thumb-based bracing, which can be a soft or a rigid brace. Topical creams, diclofenac, Voltaren, even the CBD oils, and then corticosteroid injection for thumb arthritis. All these do have evidence for for non-operative care. What does not have great evidence support are the hyaluronic acid or the PRP for thumb arthritis. And as I said, the minority of patients go on to surgery. In the operating room, we do a trapeziectomy where you excise the thumb base. We excise the trapezium at the base of the thumb. And there are a variety of techniques that the hand surgeon may do to restabilize or resupport the thumb. This is incredibly effective at pain relief for these patients, but really it's the minority of patients that need surgery. Most people can manage their flares with the non-operative care. Next is carpal tunnel syndrome, the numbness and tingling in the hand. People describe burning, tingling in their thumb, index, middle, and part of their ring finger. It's classically made worse at night. They'll say they wake up at night, they shake their hands out, and they hold it over the side of the bed. They'll do anything they can to wake up their hand. And that's really the reason why many people will present to see you or to see us is the nighttime symptoms. Other common conditions or reasons they may flare up their numbness is when they drive in their car for long periods of time or if they're using their phone for long periods of time. That wrist flex posture can really flare up their symptoms. On history, on diagnosis, the majority of diagnosis can be obtained through history alone, just talking to the patient. But physical exam can support this diagnosis. And that can include the Tinel's test, which is just tapping on the median nerve, Phelan's maneuver, which is a prolonged wrist flexion, or a Durkin's test, or median nerve compression. And performing these things, you'll ask the patient, where is it numb? And if it's numb in the median nerve distribution, that can support your diagnosis. In severe long-term carpal tunnel, you may notice atrophy or thin or wasting at the base of their thumb, which you'll see in the middle picture. And that's in late-stage carpal tunnel. Other diagnostic modalities include nerve studies, which is performed by oftentimes a physiatrist or a neurologist. In a nerve conduction, they evaluate the nerve conduction velocity. This can be a painful test, and it's another clinic appointment for these patients, and it's another time off work and another cost. Ultrasound can also be effective, looking at the cross-sectional area of the median nerve as it enters the carpal tunnel, and the swollen, enlarged nerve can be diagnosed for carpal tunnel. I'd also encourage you to consider using the CTS-6 scoring system. It's a scoring system of 6 questions you'll see here, and that's from history and physical alone, no invasive testing. And a score of greater than 12 out of the 26 total points has a very high probability of diagnosis for carpal tunnel syndrome. And the American Academy of Orthopedic Surgeons has a high recommendation to use the CTS-6 scoring system in place of nerve studies or ultrasound. So patients do not need a nerve study to come see a hand surgeon. When they see us, we oftentimes do a history and physical and will indicate them from surgery. So you don't have to have a nerve study to send them to us. Treatment for carpal tunnel, non-operative, is the mainstay is immobilization primarily at night with a nighttime wrist brace. And that helps prevent the nighttime wrist flexion when we curl up in a ball, and that's how most of us sleep. And immobilization in a neutral position can be very effective. Corticosteroid injection is oftentimes asked by patients. There's strong evidence to support this is not long-term durable relief for carpal tunnel. And so it's really nighttime bracing is our primary modality. Surgical carpal tunnel release is a very durable and effective treatment for carpal tunnel. What we do is we release the transverse carpal ligament, which compresses the nerve in the palm. In many modern hand surgery practices, as well as our hand surgery practice here, this is performed in office using wide awake local anesthesia, no tourniquet, which we call Wayland anesthesia. Patients will come in, have a lidocaine with epinephrine injection, and wait 30 minutes for the epinephrine to cause vasoconstriction. And then this is done in the office. There's no pre-operative evaluation, no pre-op clearance. There's no holding anticoagulation. There's no antibiotics. There's no anesthesia. There's no IV, and it can be extremely effective and safe for our patient population. There's questions about endoscopic carpal tunnel release. So that's a camera used to release a transfer carpal tunnel, which also can be effective. But high-level evidence will show patient-reported outcomes are oftentimes may not be much better than patient-reported outcomes with just your simple mini-open carpal tunnel release. Next, we'll talk about Dupuytren's disease. This is also something you'll see very often. Patients may not even notice this, but they may bring it to your attention. There's a bump in their palm, or sometimes there's a linear cord, or even a contracture where a patient's finger is starting to be pulled down into their palm. It's oftentimes can run in families, but it can skip generations. It has a very unpredictable progression. We oftentimes don't know who's going to get really bad Dupuytren's and who's going to have very mild disease. Luckily, only about 1 in 5 patients will have surgery within 10 years of their diagnosis, and only about 1 in 20 may have a very debilitating form of Dupuytren's. And it's important to understand that Dupuytren's disease does not have a cure, but we manage Dupuytren's just like we manage a lot of things in medicine. It is a disease that generally always will slowly progress through patient's life, and it's really hard to reverse, slow, or prevent. And when I say it's really hard, it's really we can't. There's some, with an asterisk being, there's some low-dose radiation treatment that's starting to have some evidence to consider in a very young patient considering radiation on their palm. When to refer these patients, the tabletop test is the quick, easy, effective technique when there's a contracture, when they can no longer lay their palm flat on the table. And this can be at their MCP joint or at their PIP joint. And then we think about intervention. And the intervention may be non-invasive techniques like the needle aponeurotomy or collagenase, which is also Xiaflex. Needle aponeurotomy is where we use a needle to puncture the cord in multiple locations and then manipulate the finger out into a straight position. Alternatively, collagenase is an enzyme used to dissolve away the cord. These are effective. They can resolve the cord, and it's quick, and patients get back to normal life. The trouble with this is that recurrence rates are high. In about 5 years, almost 50% of people are having recurrence or a second procedure. And so those are the troubles with those two. Open surgical release, where we excise all the diseased tissue out of the palm, is also effective with lower recurrence rates. But there's higher risks and longer recovery for patients. And it can be better for more severe disease or recurrent disease. And then lastly, we'll talk about trigger finger. Trigger finger or synostotic tenosynovitis is one of the most common complaints in hand surgery office. Patients will describe this clicking, catching, rusty sensation in their palm or a hinge that needs some oil. They'll point to their PIP joint frequently at the side of the issue, but it's really at the A1 pulley, which is down the palm, is where the tendon cannot glide through the tight tunnel of the A1 pulley. Some common risk factors include patients with endocrine disorders such as diabetes or hypothyroidism. The diagnosis for trigger finger is primarily just on your physical exam and with history, but the Quinel grading system, which you see here on the right, can help describe different severities of the disease, where early they just have tenderness over the A1 pulley, and then the stage 4 where the finger's actually stuck in your palm and they can't even pull it out straight. And then treatment. A lot of things we do to treat trigger finger, including observation alone. The trigger finger can resolve just watching it. It may resolve for a period of time and then it may come back. Bracing, high-level evidence is it's not the strongest treatment, but it can help for patients that they wake up every morning and their fingers locked in their palm and it hurts terribly bad to get straight. So a nighttime trigger finger brace can help with that for folks. And then ultimately, corticosteroid injection can be very effective for patients, up to 40 to 80% effective. However, some patients may develop recurrence after that injection. Evidence would show that patients who have diabetes or they've got multiple trigger digits simultaneously or they've had repeated trigger injections, they may not be as effective. And for those patients, many of them do want to have surgery. This is what we do an A1 pulley release. We do this in the office under wide awake anesthesia, same for carpal tunnel. And this cures or eradicates the triggering, which can be very helpful. There is some evidence to suggest that patients with diabetes, or it may be most cost effective to actually just bypass the trigger injection to begin with and go straight to A1 pulley release in the office, because it is very cost effective for them. Thank you. I hope you feel more confident seeing these common hand conditions and being able to manage them operatively, and then knowing when you can see us in the hand surgery clinic. Thank you.